Hi, everybody. It's me, Lindsay Bucklew with the TribalHub team. Excited about today's webinar with NextGen Healthcare. Today is part 2 of a 3-part series. While everybody is still trying to get in here, if you want to drop us in the chat where you're tuning in from, or I'm going to give you a second option. If you want to drop in the chat your favorite emoji. I decided that mine was the woo one because that's how I feel whenever I get the response that I'm waiting for in my email, if you want me to be honest. So today in Michigan, it is kind of a gloomy day. It was casually hailing this morning as I sent my son off to his field trip, but I'm hoping the weather turns around sooner rather than later in Kalamazoo. Let's do a couple quick introductions. Today, as I've already said, we are with NextGen Healthcare. Webinar is a community transformed RCM and the Reno-Sparks tribal success story. We've got Angie Wilson with us today, so we're pretty excited about that. Again, special thanks to the partners today. You can see Julie Labar is on here, as well as Angie. I won't go too much into introductions aside from that. Just a couple learning objectives you can plan to take away from this webinar. An in-depth look at the Reno-Sparks RCM transformation journey, some strategies for improving financial health, and the role of storytelling in engaging stakeholders and fostering collaboration. I really think it's awesome that NextGen is doing this campaign right now to highlight tribal voices and storytelling, and I really think it's awesome. Last but not least, what's going on at TribalHub? Actually, starting yesterday, we have officially hit spring regional season, which is awesome. I am looking forward to being at a few myself. We head to California and then the Northwest area coming up here pretty soon. So with that, I will kick it over to you, Julie, and let you give Angie a nice little introduction.
All right. Well, hello, everybody. I think it's probably an afternoon, morning, wherever you're coming from. It's afternoon here for me in New York State. We have a little bit of sunshine, but I could use a little bit more. So if I haven't met you before, my name is Julie Labar, and I am a value-based care and regulatory product manager here at NextGen Healthcare. But most importantly to me, I'm a nurse. And so, healthcare outcomes, particularly tribal health, has been very near and dear to me here at my time at NextGen. So I'm very happy to be here with Angie today as she shares her story with Reno-Sparks and their journey through, good financial health, but also how that all ties into improving healthcare outcomes and health overall in the communities in Indian country. So I'll let you tell a little bit more about yourself and your valuable team. So
great, thank you so much. First, let me just say Waklisi Samax, Tusika Madikcha, Ilika Tegechi, Angie Wilson. My name's Angie Wilson. I'm the director here for the Reno-Sparks Tribal Health Center on behalf of the Reno-Sparks Indian Colony here in Northern Nevada. Really happy to be on today to, highlight some of the successes from our clinic. Of course, we've worked really hard, as I'm sure a lot of you are in your tribal communities, in your areas. And I'm excited to share what we've done here and the impact to our tribal healthcare delivery system. So very honored to be here, excited to talk about what we've got going on. And of course, at the end of the presentation, if there's any questions, anything that we can do to help, I'd love to do that. I work here. I have about a 30-year tenure as a tribal health administrator, and really tribal healthcare is genuinely my passion. I love it with everything in me. So I serve, in this capacity, but I also work with the Phoenix area office as one of the representatives. I'm the alternate for the CMS Tribal Technical Advisory Group. I sit in the Medicare Medicaid Policy Committee, and I believe that I'll be also assisting as a representative for the Tribal Self-Governance Advisory Committee for the Phoenix area. For the California area, I'm a California enrolled tribal member. And I also serve the California area's Tribal Advisory Committee as a Northern California tribal representative. And I also serve as a representative on the California area's Facilities Appropriation Advisory Board. So done a lot of work in Indian country and just very excited to share where we are today. So really great to see you guys joining. So I'm gonna go ahead and get started. And if you can let me know when you can see the screen.
You're in presentation mode. You just want to swap out, Angie.
Okay, hold on. Let me see here. Just 1 second here. Let me reshare this. Can you see that okay?
Coming. Yes, perfect.
Okay. So the Reno-Sparks Tribal Health Center, like I said, is here in Northern Nevada. It's under the Reno-Sparks Indian Colony. And, you know, I'm really proud of the colony. The colony's done so much work. They've really looked at ways to, you know, expand healthcare delivery services here in the local area. The Reno-Sparks Indian Colony has just a little over 1,300 members, but they serve a large urban Indian population here at the clinic, which is pretty remarkable. So we have nearly 5,000 active patients, American Indians, Alaska Natives from all over. And, you know, they've really done a great job in administering their program and what they can do to support tribal healthcare needs. So a little bit about our program. It also provides medical services, has a full laboratory, radiology. We have dental and optometry. We have behavioral health. We have public and community health. We provide non-emergent medical transportation. We have a full pharmacy. We have a nutrition and wellness program that's really centered around our special diabetes program for Indians. And of course, we have a full program that supports not only PRC, but all referral management, as we see a lot of direct only patients here too. So that's really important to us. So, you know, the discussion really, when I was asked about doing the presentation, you know, one of the things I wanted to talk a little bit about was how did we get to the point of utilizing next gen or revenue cycle management? What does that look like? So I served as the director here for the Reno-Sparks Indian Colony's Tribal Health Center 10 years ago. And at that time, we were a Title I contract. We transitioned our clinic into a Title V self-governance compact, which was amazing to go through that transformation. But one of the things that we had also done as we looked at that time, we were using RPMS, and for anyone is familiar with RPMS, it has its challenges. And at that time, we were trying to work through meaningful use, and we would be missing out on some of the initiatives because they didn't have the reporting mechanisms that we needed at that time. So we transitioned the Reno-Sparks Tribal Health Center in under NextGen at that time. So they've been with NextGen now for just a little over 10 years. So what I wanted to do in coming back to the clinic is really look at, after taking a deep dive, looking at opportunities to have a standardized clinical and administrative workflow. And in doing that and providing a lot of change here with the growth that's happened at Reno-Sparks, being able to look at how we could create synergy in creating a core team approach. Also looking at maximizing things like population health analytics and some of the ambient AI charting needs. And I'll talk a little bit more about that later in the presentation. And then, of course, how am I going to keep up with, you know, the growing needs of our billing office when we have limited space in the clinic? And then, of course, trying to control the cost of expansion of staffing and those hard costs that come with that. And then also, how do we utilize the system that I can look at what we can do to do advocacy internally, both with my staff and with our executive health board or the tribal leadership in looking at the direction we're going to go next or how to guide where we're going, and also how to utilize the system for advocacy externally. And a lot of you in tribal communities completely understand that these are the things we're faced with every day. And the reason why that's so important is we all know that we have significant underfunding of the Indian Health Services. And this is just a graph I always use when I'm doing advocacy out in the field. We hosted Secretary of the Department of Health and Human Services, Secretary Becerra, not that long ago here in the clinic. And this was one of the major things that we talked to. You know, this is Indian Health Services. It only comes in at 50% of the funding to the next nearest federal health program expenditure. And so you can see what that looks like across the screen here. That is really unfortunate, especially because our American Indians and Alaska Native people are the only Americans that are born with a right to health care as a result of the federal trust responsibility. So, you know, when we look at the disparities of our health funding, and we look at in our tribal communities, what do we see? We have some of the highest prevalence of chronic disease, preventable disease, but we don't have the resources to be able to close that gap. So we really depend on the advocacy that's happened over time. And that has led to our opportunities under the Indian Healthcare Improvement Act to bill for those services through alternate resources, things like Medicaid, Medicare, commercial insurance. You know, those things are so important. So you can see here for us at the Reno-Sparks Tribal Health Center, this is a snapshot of what our patient population looks like in regards to alternate resources. 29% of our patient population has Medicaid, 7% have Medicare, 35% of our patient population has a commercial insurance, and 29% of our population has no coverage whatsoever. So those are all things that I have to look at when we're looking at how we provide access to care and things like that. So when I looked at the transition of bringing revenue cycle management into our clinic, the reasons why I looked at that is because we didn't have enough space. We were growing. I needed to look at how to create access. And so what I did was I actually worked with NextGen to implement the revenue cycle management function, which allows me to have additional billers that expand what our need is. And so how that works is the revenue cycle management has hundreds of people that are working in their billing, and we get teams that really help when the bills go through here. They're billing out those processes, they're working the claims, they're posting the payments, and they don't get paid if we don't get paid. So we pay a very small percentage to revenue cycle management that helps to keep us really happy with the service that we have. But these are some examples of the records or the reports that I get by utilizing RCM that I really wanted to share with you so you can see what we're talking about here to leverage the limited resources that we have in Indian country to maximize the most benefit. So this is what I call a Power BI report. So this was for the month of December 24, where we ended our year, and this is a monthly report. So you can see here for the Reno-Sparks Tribal Health Center, our monthly encounter count was 4,583 encounters, and that was across all of the services that we provide here. And so we're doing fairly well. We can see the growth. But the beautiful thing that I get to share with leadership or to our stakeholders or when I'm doing advocacy or to our staff is the significant growth. So this is what we are doing in December of 23. But if I look right down here at this time, the previous year, we were doing 2,477 encounters for the month. So we've had an 85% growth in this 1 year. That's what this is showing. The charge amount for December of 2024 was $2.7 million. And you can see a year prior, it was 1.1 million. So we were up by 133%. The payment amount, we brought in 3 million that month out of NextGen specifically. The prior year, we were 831,000, a 270% increase in our revenue. And we'll talk a little bit about how we got there and the things that we were able to use with the information we were getting out of our system. You can see the adjustments were 552. That was up from 478 a year ago, but only by 16%. Our gross collection rate was 110%. And you can see This is the type of information it will give me. The bill creation lag was 31 days, but this is actually due to some of the advocacy that we had around pharmacy. So I'll describe that a little later when the state allowed us to go back and back bill for pharmacy as a result of our expanded state plan amendment here. The payment lag was only 18 days. I could also see how many of the claims that came in were actually claims for new encounters, brand new patients, and how many were done for our established patients. Then this is the monthly snapshot. Then I can break it down per day. And so what I could see is how many encounters do we do a day? Well, we were doing 229. I could see that's up 85% from where we were the year prior at 124. I could even see where it is from last month or what that looks like in any of this information here to see if we're on, if we're on track or if there's anything that's off or what's causing that to happen. You can see the charges per business day were 139,000, up 133% from last year. That was only at 59,000. And then of course the payments per day were 153,000, up from 41,000 by 270%, which is pretty remarkable. But one of the things I wanted to show you is if I go back to the prior slide, we had 4,583 encounters. So I can see those 4,583 encounters and where they really came from. So what I'm looking at is this here. 794 were commercial. That's how many patients came in that month that had commercial insurance that we billed. 3,033 encounters were billed to Medicaid, 118 to Medicare, and then we can see 638 of these encounters were from people that had no insurance whatsoever. So you can see that's $247,000 worth of care. We did receive $10,000 for payment because our patients only pay for certain things, dental lab fees and some of the optometry costs for frames and things like that. But the rest of that we adjust off. So that's a snapshot, and this helps to keep me grounded on where we're at, especially with commercial. So if I look at any of the adjustments we're doing, I know I'm going to go back after these commercial payers because under the Indian Healthcare Improvement Act, we're allowed to bill and be paid if we're contracted or not. So a lot of times we get denied because we're out of network. We, those types of things. So we're able to send the proper documentation to be able to capture those payments. So this is a snapshot that I also like to share with our tribal leadership on what our payment details look like. You heard me say, if you haven't heard me say it, you'll hear me say it anytime you see me, that Medicaid is the highest payer of third-party revenue across the board, and you can see that snapshot here. This is by financial class, and you can see most of this is Medicaid. And then you can see the little bits of commercial and Medicare there. But this also shows me the T1015 code is the code that flips our Medicaid, flips over to our Medicaid all-inclusive rate. And of course, we bill under the Tribal Health Clinics MPI. But I can also see who our providers are that are also bringing in additional revenue from commercial or Medicare, and I can see who our staff, what providers are bringing in that revenue. And this actually has an option. There's a little snapshot that would be right here that you can press that would expand this to all of your providers so you can see where that's at, which is pretty remarkable. I also like to show this to the tribal leadership because so that they understand the importance of our advocacy around Medicaid. And if I show you this next, we break it down even further. That you can see this top one is Medicaid fee for service. The next several large payers are Medicaid managed care organizations or the CHIP program, and then all the different insurances that we have. So you can see the impact that Medicaid has in our particular clinic on the services that we provide here. And then that helps me to design programs, but it also helps with my advocacy, which I'll talk a little bit about here in a moment. What I also like to look at are the denials and tasking. So I'm looking at these denials because I want to go back and, you know, exercise our right to be able to get the services that we provided, to be able to go back to those commercial payers to get those claims paid. So a lot of times I'm always keeping a look at what do these denials look like. I can see my revenue cycle management team created 200 tasks. They completed 188. They have 86 outstanding tasks. 50 of those are over 30 days. But I can also see how many denials did we have. We had 1,500. And then how many tasks our staff created back to our providers. And then how many were completed and how many we have outstanding. And some of this right here is a new PRC program that we implemented. And I'll share that here in a moment. But on the tasking, I can see which provider, who are we going back to that needs to close those claims, by what payer. So if I need to do some outreach, this is Hometown Health. So if I need to go out to Hometown Health and do more advocacy around the Indian Healthcare Improvement Act on why we get to bill or why those denials of claims are coming in, we can drill down to that a little bit more. You'll see here, this is by type. So this is our revenue cycle management team. I can see what all the tasks are coming in. This is our billing team, how many they're creating. And this this blue color here is actually from our brand new customized PRC program that we implemented. So I have a measure to be able to see, even though it's listed as unknown, I know what it is. It's our PRC. So I can see how many tasks are happening for closing the loop on PRC. I also like to keep a look at how many tasks are past 30 days. And I look at this because this is the way that I want to say to my staff, do we need more staffing? What are the issues here? How can we help our staff as we're getting busier and busier and busier with the growth we've had in third-party revenue? When you have an explosive third-party revenue like we have had, nearly a 270% increase in a small amount of time, I want to make sure that our staff are supported in, do we need to bring more staff on to deal with the tasking? So these are things that I get provided in my reports that help me to guide where we're going in the administration of our clinical services. The next, I just wanted to show you for a lot of the programs that are out here that may have PRC. We did implement a customized PRC program into our next gen system. So I wanted to show you on the Power BI reports that I get, I can also see where we are with PRC in a moment's notice. So when I look at this, while this up here is with our regular billing, I really wanted to focus in on purchase and referred care. So I can see overall, we've had 9,195 referrals. That totaled $2 million in charges. But we only paid $733,000, and that's primarily because of alternate resources or some of the plans that we have discounted rates in. And so we were able to adjust off $802,000 of those PRC funds. But this helps to keep me in the know where we are at any given time with our purchase and referred care. And there are more reports in here that really drill down to PRC. I didn't include them for this presentation, but it's really neat to see that we've been able to transition our next gen system into actually incorporating PRC. We have always historically used our PMS, even though we're using next gen for everything else. We kept our PMS to run our PRC out of until such time that we were able to customize this entire program. So now this fully functions out of our next gen product. So I just wanted a snapshot to show you that.
Angie, there's a couple of questions real quick.
Oh, sure.
For you. Liz has a question. I'm going to flip them here, but how many providers do you have? And do you have the same number of providers now that you did a year ago?
We do have, well, it depends on what department we're talking about, but if I looked at medical in itself, we have, I believe, 7 full-time providers. That's a little more than what we had the year before, but there were some additional changes to that. And I'll talk a little bit about that when we go through more of this presentation so you can see what impacted that. So maybe what we can do is I'll run through the rest of this presentation and then we can circle back to anybody that has questions on any one of these and we can drill down a little further.
Okay.
One of the other things that I utilized here was population health. So I use population health to help me also guide what we're doing. So um, if you haven't ever met me, if you ever do, you're probably going to hear that I'm probably a more progressive tribal health administrator. And what I genuinely believe in is in my lifetime, while I'm here, before I transition on to my next journey, the thing is that I really want us to be able to effectively change the outcomes of our Indian people. It's doable. It takes work. We need resources to help us get there, but we're not a tribal health program that will just sit by and say, you know, whoever comes in and sees us today, great to see you. And then we don't see you again until whenever you come in again. One of the things that I have openly done is utilize population health analytics, which is another system that we incorporated. And I'm going to go through the next several slides so you can see how important this is for me as an administrator. And also thinking about these and how you do care in your clinic. But you can see here, this is a snapshot that I can get out of population health that will show me out of our patients, how many were last seen between 3 and 6 months ago, how many were seen 6 months to a year ago, how many haven't been seen for the last year to year and a half or 2 years, and how many have not been seen in the last 2 years. If I were to double click on these indicators here, it would bring up all of those patients automatically. And I could see a whole list of those patients, and I can shoot those patients over and do a targeted patient campaign to get them back into the clinic with the tools literally at my fingertips. Where before I would have been trying to get this list, you know, do mail outs, you know, have my staff doing calls, whatever that may be. We now have the tools that within literally seconds, I could double click on any one of these and it would bring up all of these patients, and I could move them over and do a targeted patient campaign through our patient portal, through our NG hub. You know, there's a lot of opportunities there to get people back in. And it's really important that we want people back in. We've got folks that have very significant health disparities that haven't been seen or are not coming in consistently, and we want to get our hands around that. It's similar to when I look at this from a GIPRA standpoint, even, or, you know, closing the gaps to care. I can see here how many patients may be due for access to dental services for the GIPRA measure in those taxonomies that are built in our system, for the who needs a tobacco cessation screening, the topical fluoride, and on down. If I were to double click on this, these are patients that are past due. These are patients that are near due. I can get the entire list right then and there. I can see when their next scheduled patient appointment is. I could do a campaign to get them back into the clinic to make sure that we're getting these services done. I could use these as quality improvement measures for my team. I can also look at how well our clinical support staff are supporting our providers and making sure that these screenings and things are done as a patient comes in, which is really critical to us. You know, we want to move the dial here. The next thing, and this one was probably the most profound to me when I first saw it. This is the 10-year event risk of the probability of having a cardiovascular event. This scared me like no other. When I saw this outcome, one, as an Indian myself, I'm very worried for our, for our community. So when I see that we've got in the very extreme 46% of the folks falling in the extreme are 293 patients, that's alarming. I want to know what's happening with these patients. I want to see these patients getting back into the clinic. So I could double click this right here and it would bring up those patients automatically, and I could do targeted patient campaigns to get them back in here and drive the notion. What I can also do is utilize things like this to start doing patient education. I remember my outcome when I saw this for the very first time. My immediate thought was, oh my God, where do I fall out on this thing? holy smokes, you know, where am I at? So if I'm thinking that, our patients are going to think that. And so we've done targeted, you know, health education around these graphs that just say, do you know where you fall on this metric? Make an appointment with your provider and come in to see, you know, we're here to support you. And so that really drives more education from the community level, that people want to get more engaged in taking their care more seriously. And again, how can we turn this around? And there's other risk factors in here. You can see this drop down here. There's other risk factors that you can look at, but this one, I always love to come to this one, because what it has allowed me to also do is just say, we're going to standardize our clinical and administrative workflows to get our hands around this, and how we're doing care within our clinic when patients do come in. If I look at these patients, I can see there's lab values that need to be had. And if we're doing pre-visit planning before a patient gets here, we have the better likelihood to have them be compliant and get what they need while they're here, rather than missing those opportunities and then they're gone and it's harder to get them back into the clinic. The next thing I like to use population health for in creating a team approach is our GIPRA outcomes. So we built taxonomies and a dashboard here that I can see where we're at any given point. I could literally double click on any one of these and see who the patients are that need to get back in, that are outstanding, who haven't had this done, and get them back in. So that's another thing that I really like to use. All in all, I like to look at the systems because it also helps me to do advocacy internally and externally. So just to give some examples, I've used our system, especially our population health analytics. It gives me the tools I need to be able to do advocacy. So the state of Nevada was doing an 1115 waiver called the whole body, whole mouth dental demonstration waiver, which would expand allowing diabetic adult patients to have way more access to dental care, and that we could bill for that care, where in the normal Medicaid program, you wouldn't be able to do that. They're not eligible. And initially, the state did not allow the tribes to be involved. The tribes had asked, this is prior to me coming, they had asked, the state said no. And then I came in after and really advocated for that. And I did that because I could pull how many diabetic patients, adult diabetic patients do we have that have Medicaid? We have 150 here, and we were able to really advocate to the state that we should be included in that 1115 waiver. We have 150 diabetic patients, and of course, it does not cost the state a dime because the state gets 100% reimbursed for any American Indian, Alaska Native being seen in our tribal clinics. So as a result of that, the state did change their mind, and now the Nevada tribes are involved in the 1115 waiver. So that's a really great news. That helped us to expand the care we provide. The other one was the pharmacy state plan amendment, and this was really exciting. It's exciting for us here in Region 9, for all of our Arizona, Nevada, Utah tribes. We were able to just recently get this pharmacy state plan amendment through. And for my Oregon tribes, I'm a descendant of the Klamath tribe, so I was really excited to use their example and hard work, where they got a state plan amendment through in 2017 that expanded their billable allowance for pharmacy at the all-inclusive rate without limitation. So here in Nevada, we could bill a pharmacy encounter, but we could only bill one encounter at the all-inclusive rate, no matter how many meds a patient picked up. So they picked up one med, we can bill the all-inclusive rate. If they picked up 20 meds, we could only bill the one encounter for the all-inclusive rate. So we really fought hard, went through the state, pushed, and the state finally agreed to submit the state plan amendment under this new federal administration, if you can believe that. And what happened is CMS Region 9 just recently approved our pharmacy state plan amendment that now allows us to bill for each individual medication without limitation of the number of medications, each one of those at the all-inclusive rate. So that's a significant increase to third-party revenue for all the Nevada tribes. And what it also does is opens the door for our Region 9 tribes, Arizona and California, to start advocating for the same thing. But that's a way that we were able to look at how other tribes and other states were successful, like the Oregon tribes, and how we could implement that here and utilize our data to really push that advocacy. The other thing I would say, and this is probably significantly so important for all of you that are on this call today, is it is so critically important in this current time and that we're in, where Medicaid is at risk. You can see how much Medicaid has had an impact just here at the Reno-Sparks Tribal Health Center. And I would be a significant advocate that this is really indicative of what we see across Indian country. With Indian Health Services only funded at 40% of the need, if we were, if Medicaid was deterred in any way, it would directly just devastate our clinics. So it allows, these systems allow us to do significant advocacy on the impact that Medicaid has to our clinic, the impact it's had to access to care, which is significant. You saw that, how many more encounters we're doing, how much more people we're getting in for care. We've been able to have an impact on staffing as our revenues increase to add more providers, add more specialty care, add new equipment. We've been able to expand our facility. We've been able to expand into tribal sponsorship and pay for the premiums on our healthcare exchange or pay for Medicare Part B or D. And of course, to always advocate that Medicaid is there as a trust responsibility, but these give us the tools. So in all of this work that we've done, this is what our revenue is looking like now. So in 2024 to 2020, we averaged about 6 million in third-party revenue. In 2021, we received a little bit of extra funding because of COVID. And in 2022, there was still some COVID money, but we started to advocate for some of these changes. And because of our advocacy, being able to use the data and kind of really open the door, kind of streamline what we're doing here, utilizing tools like population health to drive people back into the clinic, using AI, ambient AI in our charting to make our visits more effective. We have implemented that, and our revenue is now, we closed 2024 at just a little over 18 million. And that's without the new pharmacy state plan amendment. We're able to now expand pharmacy billing, like I said, for each individual medication at the all-inclusive rate. So I am sure our 2020, just looking at the numbers alone, this will significantly grow in 2025. All of which are so important for us as we look at the tribal healthcare system. So that is my presentation, and I'm happy to go back and answer any questions that you may all have.
There's one in the chat. Angie, what patient portal do you use?
We use IntelliChart, and in fact, we're really excited about it. We've tried to also hype up the community to be excited about it, but we use IntelliChart.
Yeah, any other questions right now? Does anybody else have any questions?
One of the things I'd like to say to you all is, one, I appreciate the work happening in Indian country. It is so important, and to me as a tribal member and as a health advocate, as a former tribal leader, I cannot express to you the importance of what we do in our communities. And like I said, we have the opportunity to have impact to generations that come behind us. And that's our mission here at the Reno-Sparks Indian Colony, is to transition what it looks like for their patients, for their community, their tribal community, and the impact they're having to the thousands of urban Indians that come to this clinic is pretty amazing. But it can't happen if we're not all working together to get there. And really, the utilization of these systems are so critical to allowing us to be as effective as we can be. And like you said, it is our responsibility. I feel like that so much as a tribal member. It's our responsibility to do everything we can to support our people. And I'm just really proud of what we've been able to do here. So,
As
yeah.
you should be. There is one new question, Angie. Do you
Sure.
have any billers on staff? And if so, do they do any claims filing or follow-up?
We do have our billing staff. And in fact, when we transitioned over to revenue cycle management, which is a whole billing system, a team, the worry was would we lose our staff? And the answer is no, we didn't. We left our staff on. And the reason why that's so important is, remember the slides I did on tasking. So revenue cycle management, the system is built with a background business processor that when a claim comes through, our staff can see that claim. So if there's issues, they can correct those before they go. And that's what happens between that tasking network between revenue cycle management and our staff, because revenue cycle management team cannot go in and make any changes. So our billing staff actually are so critical because they take those claims and they're working with our providers to go back and adjust or make any of those changes or put in the right insurance or whatever's needed, so that when those claims go through, they're going through clean. And then the revenue cycle management team posts all of that, so our staff doesn't have to do that. So it's really a great team effort where we have our staff, our billers, who are also coders, to be able to look at that and work with our teams internally. And then the other thing we've really done is utilize our business office to look at how are our systems working? How can we work with our front end users to make sure that everybody's got this down? If we see errors, we've got a front user group team that takes all the schedulers and our billing team, our patient registration team, and our patient benefit coordinators, and they all meet once a month to look at who do we need to support patient-wise, what providers need to correct these errors, what are things that we can do to be more effective? Did we bring the right insurances over? What are we seeing with that? And so we've really created that synergy of a core team in different areas. And that's really, really worked for us. I mean, if we didn't have that, I can't say it enough. I'm so incredibly proud of our staff here. And it's taken a lot of work, but we have such a great team, and looking like everybody's vested to how do we make this to be the most efficient it can be. So yeah, we kept them on, and really the level of growth we've had in our third party, will probably hire more on-site staff to work those tasks. Because it really justifies the level of growth. I mean, our revenue is 3 times growth in less than 2 years. So that's pretty massive.
Yeah, amazing.
Yeah.
Well, I just want to pop on and say thank you guys so much. Angie, Julie, this has been an awesome webinar. Angie, every time you use the word advocate or advocacy, it just like triggers in my brain, and you're doing awesome. And as you can see by the chat, others are feeling the same way. Speaking of the chat, I am going to throw in here right now, as I've mentioned a few times, this is part 2 of a 3-part series. So if you would like to register for the 3rd part, which will be next Tuesday, the 22nd at 1 o'clock, there's a link right there. You can also find it on our website. And for those of you who may or may not have joined late, a link for this particular recording will go out within 48 hours directly from Zoom. It will also live on our website, so you'll be able to access it there. Thank you guys so much. This has been awesome and very informative.
Thank you.
Thanks, Lindsay.
Bye.
Bye, everybody.